Thank you all for joining us today. Before we get started, I do want to take a moment to just introduce Pat. So a little bit about her. She is an MN, BSN, RN. She's the Regional Director of Education and Compliance with Arizona Care Hospice. She obtained her nursing degree from Marymount College of Virginia and obtained her Master's of Nursing degree from the University of Phoenix. She's been an RN for 46 years and in hospice care for 26 of those years, specializing in leadership and management. Pat teaches all over the Valley and is a certified hospice consultant with CHAP. Her consulting practice focuses on surveys, education, and specialty education programs with a focus on instructional design and stand-up training. Pat consults all over the United States and has helped many hospices with plans of corrections and focus surveys. Pat has taught nursing at the University of Phoenix, ASU, and U of A. So today is webinar number 3 in a series of webinars titled The Dying Process. Please visit after the webinar, of course, visit arizonacarehospice.com. You can register for upcoming webinars as well as watch our previous webinars. So without further ado, Pat, I will let you take it away.
Thank you, Allison. I appreciate that. Good morning, everyone. Thank you for joining us today. As Allison was explaining, this is our 3rd webinar with Arizona Care Hospice. There is a webinar series that we do every month. So if it's a topic that you're interested in, please feel free to register at www.azcarehospice.com. Or if you've missed one of our webinars and you want to listen in on a previous topic, you can certainly find all the previous recordings on the website. So I want to welcome all of you today, those of you that are local and those of you that are out of state. All different disciplines have registered today, which is kind of nice. We have long-term care, we have hospice people, we have acute care, rehab people. So welcome, everyone. This is a topic that is very near and dear to my heart because when I train nurses out in the field, I get asked tons of questions about the dying process, especially for people that have never done hospice before. And what are some of the things that they should look for, and how do we make the dying process a process that is comfortable for every person that's going through it? And you know that all of us at one time or another are going to have to go through something like this. So I think the more we understand about it, the better we're going to be and be able to help our patients and our families. So today, first of all, we'll talk about the objectives. I'm going to go through with you the stages in the dying process. And I don't mean, the Kubler-Ross stages, you probably all know those. These are stages that we see in the hospice environment. And we'll explore and examine the physical symptoms that you'll see. I'm going to touch a little bit today on the spiritual aspects of dying, the social issues around dying, and any other issues that you see. You'll have an opportunity to ask me questions, of course, at the end of the presentation, but we'll try to cover as much as we can. And then the last piece that I want to talk to you about, and you may or may not be familiar with this, is a new concept called the death doula. And what is the role of the death doula in the dying process? We have seen within the last year or so, a lot of hospices hiring death doulas, and they have a role in our team as well. And this is something too that you may have seen in practice, or you may be interested in something like this yourself. And I'll talk a little bit about what you can do to, become a death doula if this is something that you've always wanted to do. So these signs and symptoms that we see in a person who is getting ready to pass on occur a few hours, a few days before the death actually occurs. And so not everyone's the same, but there are certain characteristics and certain signs that we see when the body systems are slowing down and when they actually cease to function. So there's no particular order sometimes in which these events occur, and some patients will have all of them, many of them will have some of them, and there are some people that don't have any of them. I used to say to people, we used to get referrals, maybe they weren't quite appropriate for hospice, and we didn't really see them as having a prognosis of less than 6 months, and then all of a sudden that night they pass away, and they're like, see, I told you they were eligible, they were appropriate for hospice. My answer to that is always, people will die all of a sudden many times, all the time, and it doesn't necessarily mean that they met criteria for hospice. Classic examples of that are people that have heart disease that we don't know about. and suddenly have, a heart attack and pass away, and they're like, oh my gosh, we didn't even know this happened. So people do die suddenly. It's much more traumatic for families when that occurs, either an accident of some kind or an illness that they didn't know about. So we try to help those families as best we can. And remember that hospice has a wonderful bereavement program, and we follow our patients for a year after their loved one has passed away. And we're also available for those that are not on our service as well. So the symptoms start first with a person having less of an interest in eating and drinking, and they may only want enough fluids to keep their mouth from feeling dry. This is probably one of the hardest symptoms I think that families struggle with. And the reason for that is because we're such social creatures that we really believe that if someone would eat, they would get better. And that's not always the case. One of the things I try to explain to families is, I know you're worried because they haven't eaten in 3 or 4 days, but they truly are not hungry. The body has a way of not producing hunger at the end of life. So this is something a lot of people are not aware of. Fluids, on the other hand, lack of that would cause dehydration, but dehydration is not painful. There's a webinar that I did last month that you may have been a part of on food and fluid at the end of life, and tube feedings and that kind of thing. So if you haven't listened to that, you might want to go back and listen to that, because you'll see that the disease process, actually has a way of letting each one of our organs shut down naturally towards the end of life. So there is less interest and there's no hunger that's a part of that. So I didn't want families to worry about that. So we do explain that in great detail. But what can you do when they've offered that so you can still feel part of their life and part of their process? You can offer food, don't force it. You can offer fluids. There are medications that we could give to increase an appetite, but at that stage, usually it's not warranted to even do something like that. So for example, I can remember the night before my father passed away, he asked for McDonald's. So naturally, you give them whatever they feel like eating, and I think at that point in time, it all depends, we call those cravings or whatever you want to call them, but offer them whatever they want to have. If it's a shot of bourbon or if it's some Dr. Pepper, whatever it might be, we don't hold back at the end of life. So at that point in time, food and fluids are not as important as they have been. Another symptom that typically diminishes and decreases is urinary output. We always would look at Foley catheters, and we could tell, the kidneys were shutting down by the less amount of urine that we would see in a Foley. This is not painful either. We don't need to do anything unless the patient has a desire to urinate. They're still communicating with you and they cannot. So naturally, we don't want anyone to feel uncomfortable. We want families to call us when that happens. We can certainly, put a catheter in and drain the urine out. We can do other things to get them to urinate. But the fact of the matter is that unless the patient complains of being uncomfortable, this is really not something for you to worry about. And just know that it's part of the process towards the end of life. Patient will sleep more and begin to detach from the environment. I notice this all the time. You might see a patient on Monday and Tuesday and they're actively talking. You know that they're failing. You can see the color changes and that kind of stuff. But now all of a sudden, come Wednesday and Thursday, they're sleeping. They're sleeping 19 to 20 hours a day, or maybe even longer. When we have patient care conferences every 2 weeks at all of our sites, it's one of the things I repeatedly hear the nurses talking about. Mr. Smith or Mrs. Stevens is sleeping now almost the entire 24 hours. Does arouse when touched, but is not really, doing anything but sleeping. So let them sleep. Do not feel compelled to wake people up. In hospitals, there's routines. You wake people up to check their blood pressure, do their vital signs. There's absolutely no reason in hospice to do any of those things. Let the patient sleep as much as they want. Families need to know when they're at the bedside, the last sense that we have to leave our bodies at the end is your hearing. So I always tell families, go ahead and talk to your loved one, say whatever you want to say. I encourage people that live out of state to come in and see their loved one, because typically if they haven't seen them, That's a regret that people have, and there's nothing you can do about it. People are going to die on their own terms when they're ready, and lots of times, as a lot of you know, they'll slip away when you're not in the room. Doesn't mean that they don't want you there. It just means that this is the way that they've chosen to go. So this is something important that I want people to understand, that sleeping a lot and all the time is part of the dying process. Another symptom that I see quite often, and I'm sure you have too, is mental confusion. The reason for the confusion is the lack of oxygen towards the end. Everything that they have, every senses, every bit of breathing is taken out as the dying process continues. So what we do in that situation is, as they respond to us when we remind them that we're there, we're present, the time of the day, what day it is, and let them know, are you hurting? Is there anything that you need? So mental confusion could go anywhere from mild, not recognizing who you are, to not recognizing their surroundings, to getting very restless. And that's a term called terminal restlessness. And we'll talk a little bit about that, in the middle of the presentation. But I have seen it with my father specifically, the day before or a couple of days before, was extremely confused. I remember going into the inpatient unit at the hospice where I was at, and him telling me that there was a huge argument last night outside his room. And the nurses were fighting and the doctors were fighting. Well, I knew none of this could possibly happen. But I never said, oh, that didn't happen, or that's not true. I said, well, I'm sure it must have been very upsetting for you to hear that. Did you call the nurse? He said, no, I didn't want to bother anybody because they were having an argument. And I don't remember what the argument was about. So that's part of the mental confusion that you'll see. And that's from lack of oxygen, especially with cancer patients. Everything that they have has been taken and fed through those tumors that they have, and they become very, very confused from the lack of oxygen. The patient may be disturbed by strange dreams, taking a journey, or seeing a loved one that has died previously. We hear that a lot too. They've seen, family members have appeared. They might see someone in their room. My mother-in-law specifically one day said to me, we were at her house and she was dying and she was sitting in the family room, and she said to me, she said, Pat, I see Bill over by that tree outside. And I thought, okay, so she could see out through the backyard, and her son, Bill, my brother-in-law, Bill, had passed away from cancer a couple of months before her. And so her seeing him is very, very real to her. So arguing with them about, no, there's nobody there, no need to be worried about that. You just kind of nod your head, tell me about it, what do you see? It actually brings them comfort. So if they get upset or anything, then you can tell them, well, this is just something that's passing through. I'm sure everything will be fine, and just move on to the next topic. But if it brings them comfort as they awake, talk to them in between these periods of sleep and periods of orientation. So reassure them, obviously, in a calm manner, that this is all part of the journey that they're taking. Vision and hearing may become somewhat impaired, and speech may be difficult to understand, as we go through the end. Vision and hearing are probably the last ones to go, hearing especially, but speech may be difficult to understand because they may have some medications in their system, so they're a little bit groggy, or they may simply be, getting towards the end and finding a piece there and really can't talk the way they normally would. So speak clearly, but no louder than usual. You don't need to shout as if they were deaf. Keep the room as light as the patient wants it, but they might just want a night light. Carry on all conversations as if they can hear everything that you say. Sometimes you may not have anything to say, but you could just sit there and hold their hand. I did that with my mom. My mom was comatose before she passed away, and I just sat there with her. So I think they know that you're there, and they do find comfort in that. One of the most troubling things that families go through is what we call secretions, the death rattle or the death gurgle as they breathe through their mouth. So respirations become shallow. They may, grasp for air, or purse lip breathing, or fish breathing, if you remember how fishes do that. What happens is fluid accumulates in their mouth. This is not And I repeat that for families that are tuning into this. This is not distressful to them at all, but it is distressful for you. Many times families will ask us to get a suction machine. Let me caution you that suction a patient at end of life is detrimental to them. That is troublesome to them. So we do not suction patients at the end. What we do is give them medications. We use scopolamine patches. We use atropine drops under the tongue. Those will help with the gurgling or the death rattle. Not every patient will have that. Oxygen is also a comfort measure. Some families will ask us to discontinue oxygen, but oxygen is not prolonging life. It's not like a ventilator. It is actually a comfort measure. So try placing the patient on their side to help drain some of the fluids. You'll often see us come in when you call us. We'll cleanse the mouth out with swabs or touthets, if that'll help. We'll allow them to be able to swallow. We'll give them sips of water or a washcloth dipped in something, and we train our nurses to use the medications to lessen secretions, and we typically will come in and reposition and turn people. We've even had a patient, his favorite thing in the world was Dr. Pepper, and his family actually wrote a letter about this. So what we did at the end for him was we took moistened toilettes and washcloths, and we dipped it in Dr. Pepper that was cooling. We didn't make it freezing cold, but we made it cooling. And we would put that in his mouth. And that seemed to bring him some comfort and allow him to swallow better. And it was a taste that he had to the end. So that's something that usually stays with them. So if you know that they have a favorite beverage that you want to, put a washcloth in or a toothet, that is something that would be helpful too. Breathing, of course, becomes irregular. There's periods what we call apnea or pursed lip breathing or chain stroke breathing. Just raise the head of the bed, turn them to the side a little bit, use medications. Now, there are some medications that are very effective for breathing, one of which is morphine. Families really freak out about morphine. One of the questions I get all the time is, does this speed up the process by giving them morphine? And the answer to that is no. We give very small amounts. It's not addictive, and it does help with your COPDers, emphysema, lung cancer patients. We also use the atropine drops under the tongue and scopolamine patches. I prefer scopolamine patches. I've used them in the inpatient setting quite often. They seem to really help a lot with the breathing issues. Patient may become restless and anxious. Some of the signs of that are pulling at their bed linens, reaching in the air with their fingers, or having, visual hallucinations. They see things, could be animals, lions, tigers. I've had that before. I see a cat, I see this or that. I reassure them that this is okay, that you're there, where they're at. Use a calm voice. There are medications that we use for anxiety and restlessness. We use Ativan, lorazepam, Ativan. All of those are very effective to help with the terminal restlessness of the anxiety. Not everyone will go through this, but there are several people that will. And so what we want to make sure is we prevent any anxiety, because not only is it troublesome to the patient, but it's also troublesome for the family to see their loved one go through that. Their circulation also decreases. It causes a bluish tint to the skin. One of the common things you'll hear hospice nurses say is your mom has started to bottle. They're starting to become diaphoretic or sweating. The skin touches the bed linens. Their skin becomes darkened, and their pulse may be hard to find. So that's how we know it's coming close. We've seen it, nail beds, lips become a little bit bluish. Color becomes ashen or grayish in color as they, the eyes become a little bit sunken. None of this is painful. It's just a circulatory process of the organs. All the organs shut down at their own speed. So provide blankets, remove blankets, whatever I'm cold, I'm hot, whatever they need. They also will spike a temperature at the end, as high as 103, 104. So what I recommend for that is using Tylenol suppositories, to make the heat go down a little bit and make them comfortable. But remember too that fever is something that is very common at the end, a couple hours before death. The patient also may lose control of their bowel and bladders, especially if they were continent before. that is very common as well. So we make sure they're diapered, or we want to prevent them from being embarrassed if they're still awake, and that kind of happens every once in a while. So we change frequently. We protect the bed with extra padding underneath them. We don't want a double diaper at all, ever, but so we change more frequently, and we want to make sure that we make sure their dignity is intact. We're preventing any breakdown of skin. We treat the skin with lotions, and make sure they're turned and repositioned, because they will lose control of their bowel and bladder. So the steps in the dying process that I want you to be aware of, which we've talked about with Elizabeth Kubler-Ross, are things that are still prevalent to this day, but they're denial, anger, bargaining, depression, and then eventually acceptance. By the time we get most people in our hospice program, they could be at any one of these stages. Not everyone comes to us with the acceptance part of it, and that's why we rely very heavily on our team of people. I could never do this job by myself. I rely on the chaplain, the social worker, their visits to the family. They help work through the anger issues. They can help with depression. We do have people on medication for depression, for things for sleep, to help them sleep at night. We do use Haldol for physical symptoms as well as restlessness. We use it also for nausea and vomiting. So some of these things affect people in different ways. And so I really encourage you, if you are a hospice person that works in hospice and are listening to this, that you rely very heavily on your team to help you get your patient and family through these particular areas that are causing them difficulty. Some people come to us very, very late in their disease process. We had a couple this week that came on service on Monday and died on Tuesday. So the acceptance part of it is already there in most of those people. But remember too, even if they're young, we had a 52-year-old gentleman this week who had liver failure that came on service, I think Monday or Tuesday, and had passed away the very next day. So we obviously want you to get your patients to refer to us before then, so we have more time to work with them. But that's not always possible, because people sometimes would be in denial. So now we're going to break things down to symptoms and causes and effects right through the day of death. So we'll start with 1 to 3 months prior to death. These are some of the most common things that you're going to see people start to withdraw from you. It's because they want to go on their own terms. Men and women treat dying differently, believe it or not. Research has shown that women may go and revisit their lives. You know how we lay there and worry, and we think about things at night. We start revisiting, where we were at, what we could have done differently. It can be traumatic for a lot of people. Not that men don't do it, but women tend to do it a lot more. Men will withdraw more and decline visits, especially from guy friends, people they hung out with, special clubs that they belong to, families and neighbors. They tend to withdraw a little bit more. They will distance themselves. Patients will distance themselves from visits. They start to eat less, which we talked about a little bit, and they no longer are hungry or thirsty. And that is one of the most difficult things, I think, that we go through when we see people that are dying. 1 to 2 weeks prior to death, we start to see some of these mental changes that I talked about earlier. Hallucinations, depending on medications that they're on. They may sleep more. They have delusions. They think things happen that haven't happened, like the fighting going on outside of my father's room. Naturally, when I talked to the nurses about that, no, of course, none of that took place. The picking at the sheets. I've seen this a lot too, where they're picking at things in the air, and the agitation. The agitation is part of terminal restlessness, and of course, trouble swallowing. So no one wants to have any one of their patients go through any of this. So the important thing to remember is, if they are going through this, you, one, discuss it with the physician. Hospice physicians know exactly what to do at all of these different stages. Discussing with family what you're seeing, how normal this is, and that we can do something about it. talking to the patient about it as well, and then making sure you're talking about it with your team members, especially if you're new to hospice and you're learning about these things. You might be struggling with your own feelings about these, especially if you've had family members that have gone through them and you really didn't know what to do. Remember, everything's a learning experience for all of us. We learn from our patients, so we learn more about what to do at different times of the day or night. 1 to 2 weeks prior, you'll still see a decrease in body temperature. You know, when you touch someone, gee, mom, your legs are cold or your hands are cold, their blood pressure tends to drop. How many times you've gone in a room and there's like, you know, one number, they're like 34 over, you know, something, or 64 over 20, and you know that things are getting lower and lower. Pulse becomes irregular. There's definitely an increase in perspiration because the body is sweating out the oxygenation. Their breathing changes, their color changes. The congestion may or may not be a problem. Lung conditions, although my dad died of lung cancer but didn't have any of the death rattle or any of the congestion at the end or any of that fluid that you hear in the throat, thank goodness. But if he did, you know, I was ready, you know, with my morphine and also ready with my patches and atropine if needed. The other thing is sudden movement of the arms and the legs, very restless. You know how when you can't sleep at night, you know, the sheet's on, you take the sheet off, you turn, you can't quite get that position right. So what I always say to the patients or the nurses is try to be more in tune to your senses so you can help them. What do you think is causing them to move so much and have all of this rigidity that's going on? And then once you can probably identify what it is or give them some medication to calm them down, things will be a little bit better. 1 to 3 days prior to death. This is what we call the death rally, if you want to call it that. There's a surge of energy. I never thought that there was any truth to this before I became a hospice nurse. I used to hear about it, but never thought, but boy, was I ever wrong. I saw it with my own father. You know, a couple hours before, he actually woke up from his coma, was talking about things that happened years ago, was having a conversation with me about just about current events. And then the next thing you know, he slipped back into his coma and died. This is very, very common. We call it a surge of energy or the rally. And rallies can happen a couple of hours before, a day before. They can happen more than once. The thing about a rally that you should really be aware of is it gives false hope lots of times to families. They will say to me, oh, he's going to be fine. He's come out of this. We're going to be able to take him home in a couple of days. And you don't know for sure, you know, naturally miracles do happen, I'm sure, but most of the time it's a rally and they'll go right back to the way they were before. Congestion tends to increase a couple of days before. The hands and feet become mottled. I talked a little bit about that. That bluish discoloration is almost a gray blue. Nail beds become blue. They start to turn in their lips. And then most of the time they become unresponsive. And that's how I know we're like hours away. How long they go unresponsive is all individualized. I truly believe that people die on their own terms. How often have you heard, you know, I went down to the cafeteria to get a cup of coffee, came back, and they were no longer here. So that does happen. And people tend to feel guilty about that. But you need to know that this was something that your loved one went on their own terms. You know, who knows? Maybe they saw a loved one that passed before them and they came to get them. We truly believe in that. You know, God does, you know, wonderful things when people are at the end of life and takes that suffering away. What can you do for your patient? Listen and offer support. Obviously, if they're still speaking to you, you want to be a good listening ear. Our chaplains are very good at this. They've been able to teach us a lot about what to look for spiritually with people. We'll talk about that a little bit later. We want to validate their feelings. You know, yes, Dad, I'm sure there was a huge argument here last night. I'm really sorry you had to go through that. My first thought was, oh, geez, you know, how do I explain to him that this didn't take place? You know, and that's the daughter in me wanted to say, no, none of this happened. You're fine. But then I had to take a step back and say, you are a hospice nurse. You know that this goes on. So you want to address the physical symptoms. You want to explain to families at the bedside. This is one of the things that I thought was very important. Every single step of the way, while I was on a shift in hospice inpatient unit. I would explain what I was seeing, what I was doing, what I was going to do, what I thought they were going through, and then I would offer encouragement or whatever it is I needed them to know. I gave medications for each symptom as needed. I explained to the family, this is morphine, this is how much I'm giving, this is what it's for, this is atropine, this is for the secretions that you're hearing, this will help with that gurgle that you keep hearing. Well, here's a reason why we're not going to be doing suction, because this is going to do something better. And then, of course, provide privacy. I saw that in some of the inpatient units I do consulting on, where they have more than one person in a room. Most places have private rooms, but there are sometimes two patients that are in a room. And the conversations that I have heard between two people that are dying is just amazing to me. Their comfort for each other. They become friends. A total stranger who they've never known their entire life suddenly is their partner in death. And it's just amazing to me how people can connect on so many different levels. So let's talk a little bit now about this terminal restlessness that I mentioned to you earlier. It is a very common issue at the end of life. It's also known as terminal agitation. It does pose many challenges for families and caregivers because typically it's an outburst of emotion that the patient goes through. And sometimes their behavior can be very aggressive, trying to get out of bed, trying to sit up, sit down, very, very restless. Or if they're sitting in a chair and the music therapist is there or the pet therapist is there, they want the dog to go away or they want the dog with them, and they get up and down with emotions. So it can be difficult to deal with. We as a hospice, and all hospices should do this, remember that you are covering medications for everything related to the terminal illness and any other diagnoses or factors that are going to contribute to their demise. So just because someone is dying of lung cancer and you're medicating them for secretions and for pain, you also must cover any sort of agitation, sleeplessness, uh, any sort of depression issues, anything that's going to breathe them comfort of any kind. We even cover things for, GERD, if they've got, problems with that, or they've got acid reflux disease. These are all comfort issues. So remember that you should be covering those medications. Terminal restlessness is caused, in case you ever wondered what causes this, by a physiological changes to the body that occur during the dying process. So as each organ shuts down, there's a metabolic failure. So the brain is not receiving all the oxygen, which I talked about earlier. So certain types of things will occur. It can occur from certain types of medications. Not everybody reacts to medications the same. So you want to know too, people say, well, I'm allergic to morphine. Well, tell me what that allergy is. It may not be, a certain allergy, but it may be a reaction that's not very favorable to that medication. So we want to have, good pain management. No one should die in pain. Let me repeat that. No one should ever die in pain. Death occurs to all people at one time or another. We want to make sure that this is a process that is very favorable to the dying process. And the reason I say that is because as a hospice provider, you only get to do this once. There's no do-over on a death. So if you make a mistake or if the patient does not do well, the families will not forget that. And we don't want to leave them with that lasting reminder that this was not a painful death. So we want to do everything humanly possible to make that as positive experience as you can. We know that they're no longer going to be able to see their loved one. We understand that, but we want to make sure they understand that this is part of life. It's part of living. When you do that life review, did you do the things that you wanted to do in life? And the reason I say all this to you is because if you talk to a hospice patient at the end, one of the things they'll say to you 99.9% of the time is, I wish that I had done this, this, or that. And gee, that chemo did provide me with 3, 4, 5, 6 more months of life, but at the expense of being sick all the time where I could have been doing some other things. So it's not for everybody. Some people do this because they want their families want them to. They want them to keep trying. But sometimes it's not the goal that the family or the patient themselves, I should say, really wants to have. Okay. So treatment for terminal restlessness consists of, having balance between pain medications. There have been situations where I've had trouble balancing them. One time I had a liver failure woman in her 50s who I just could not for the life of me control her pain. And I knew that the end was coming. I knew it was near. I tried everything. I called every doctor I knew. I talked to every nurse I knew. I consulted everywhere, and I was having trouble. So my last day, or the 2 days before when I was there and I knew I was having trouble with her pain medications, I just sat down with her and I said, Mary, can you tell me if there's anything different or new with you, or anything like that I don't know about, or anything you want to get off your chest, because I'm still playing with this medication and I can't seem to get the right amount. And so she said, no, everything's fine. She said, it's not that bad. She said that my priest came to see me today, but I didn't get communion. And I said, oh, well, from your parish? And she said, yeah. And I said, well, can you tell me what happened? And she said, well, she said, I was telling him about some things. He was asking me some questions. And he said, Mary, you have to go through a repentance process because you really didn't live a good life. And before you get to heaven, you're going to have to repent. Well, bingo, the light went off in my brain. And I thought to myself, this is not about physical pain. This is about spiritual pain. This lady cannot die peacefully because the priest had told her that she still needed to go through, some sort of repentance for whatever sins she committed. So now I was faced with a whole different problem here. I wasn't sure I was 100% right, but I figured I probably was. So what I did was I left her, I got in the car, and I drove right to the rectory. And I knocked on the door and I asked the lady at the door if I could see Father, I can't even remember his name now. And she said, well, he's up in his room and he's resting now. I said, well, I need to see him right now. And she said, well, I'll tell him you're here, but I don't know if he'll come down. I said, well, I need to see him. And I went right in and I said, which door is his? And I banged on the door and he came to the door and I said, I need you to do something for me. I never said, you're right, you're wrong. I just said, I need you to do something. I need to get in the car and come back with me and talk to Mary and tell her that Jesus forgives all sins, that she's going to go to heaven, and that you're going to give her communion, because I need this lady to have a peaceful death. And so he did. He got in the car and came back with me, and he told her that. He told her that he never meant to mean that she wouldn't go to heaven, just that she had to go through confession. So whatever religion they are, or whatever their faith base is, you need to know that it may not always be physical pain, and maybe some other type of pain that someone is going through. So you could use specific opioids. We use Ativan for restlessness. We use Tylenol suppository for elevated temperature. We use atropine scopolamine for secretions. We speak calmly and softly. And obviously, if you have something in your practice that you've used that's worked, definitely share it with your team, because it's very important for us to get this right. And while physical pain is very much a part of hospice and dying process, and we want to alleviate that, there are other types of pain that people are exposed to. Now we're going to talk a little bit about a new concept that has happened in hospice and death and dying, called the death doula. There are birth doulas. Some of you may be familiar with that, those of you that work in labor and delivery and have seen that. But a death doula is someone who actually assists patients and families through the dying process. We do too, but more and more families are hiring them, more and more hospices are hiring them. They're actually community-based. They go through a program where they learn about death and dying, just like we have in hospice, and they help families cope with the death, and they stay with them. They actually supplement the hospice, and they really have a purpose and a meaning. I talked to a man last week who had hired a death doula for another hospice that I was doing consulting with, and he said to me, this woman actually did all our invitations for the funeral. We wanted a celebration of this woman's life, and we were so overwhelmed with families flying in from all over, that the doula actually did all of the legwork for them, kind of like a little bit of what our social workers do, but much more focused on really, going through the dying process and helping the patient and the family. So they really are becoming very purposeful and very meaningful at the end of life. So what do? They provide support. Support for the patient, obviously. They stay at the bedside as long as they can. They may go and have a couple of hours sleep and then come back and augment our care. They provide all kinds of resources for burials, funerals, invitations, education. They provide friendship. There's some families that I know from some of the hospices that have had a doula that they're still friends with them to this day, and their loved one died, several years ago. So it's a position that if you're that you're interested in, you can certainly do that, especially if you're retired and you want some extra things to do. A death doula is becoming very important and very prominent lately. So other than sitting at the bedside, their death planning is remarkable. I mean, there was this one woman who had a death doula she had hired because she wanted her to help prepare her grandchildren for the impending death that was coming. So she made sure the death doula did her research on children's books that were available, to children. She would read to the children. She would babysit when needed. I can remember when my dad was dying, my children were little, they were still in like grammar school. The hospice staff actually watched my kids so I could stay, with my father. Of course, I worked for the hospice, so that had something to do with it. But hospice staff will do that if needed. And we also use, remember too, hospice volunteers. So they perform activities, they do planning, and they're totally non-medical support. So they don't provide, the medications, they don't provide any sort of teaching in terms of medication stuff, but they are there for support for the patients and families. So how do you become one of those in case it's something you're interested in? My recommendation is you first start as a volunteer with a hospice. So if you've never been around the dying process, a hospice is a good place for you to learn that. We have, many volunteers on our hospice, the Arizona Care Hospice, in all of our locations. All the hospices I consult with, I talk to the volunteers. I attend their volunteer celebrations when I can. I speak to all the communities and their churches that have volunteers. So I do a lot of community work too, when I can get out there to help with that. So we want to encourage people that have an interest in being a doula to definitely volunteer for a hospice. There are certifications now that you can get as a death doula in your community. All you have to do is Google death doula, and all kinds of information come up. There's YouTube videos on it. And then my third recommendation would be to intern with a hospice, or go with a preceptor. We have interns of all different disciplines at Arizona Care Hospice. We have social worker interns, chaplain interns, all kinds of people that want to learn about the dying process and are pursuing some sort of a degree, in that avenue. So those are the areas that I oversee. So if you have an interest in being an intern, make sure that you contact me, and then we'll certainly be able to help you with whatever it is that you need. So in closing today, we'll have a couple of minutes for questions. Remember, hospice is about living your life, with the intent of achieving the goals that you have. Remember that families will always remember that death experience. I can't emphasize that enough. If you read any of books on death and dying, Barbara Carnes is another famous woman that we buy all of her books. She has these end-of-life books that we actually give to families, and in those books explains all these things that I've talked to you about today, about what happens a couple of months before death, a couple of hours before death, so families have a reference that they can use. We have found in talking to families that one of the biggest things that we hear is, if I had known that I didn't get to do this or this, I would have spent more time in this area. So make sure that their goals are being met to the best way that you can. And if someone, if you have a loved one that's going through chemo radiation, just know that it's fine if that's what they want to do. It definitely is up to the patient to decide. But if they do tell you, I don't want to do this anymore, I want to be able to take that trip to Italy, or I want to see my granddaughter get married, or whatever it is, it may hurt you because you think they're giving up, but just know that they're not giving up. It's all about living, and it's about their goals. So with that, we'll be able to take some questions if anyone has any questions. Allison, will you monitor the board? Let me know.
Yes, of course. I just want to take a moment to thank you for taking the time to share this information with us today. We do have a couple questions. The first one is you had mentioned dying people sometimes see loved ones that have previously passed.
Mhm.
How common is that, and what does that mean? What can the family members take from that?
Actually, it's a lot more common than you think. They may see someone on their bed. That's the most common thing. An aunt, an uncle, maybe their own parents, a child they have lost, a boyfriend they had years ago. I've heard all kinds of stories about that. It's a lot more common than you think, and it's actually comforting to the dying person. It's not something that's frightening. So I've never, ever in my 26 years had a dying person say to me, and I've been with a lot of dying people, oh my gosh, I'm frightened to death because so and so has come back to haunt me. It's not like that. So it's a very comforting thing, but it's very, very common.
Okay, thank you, Pat. You mentioned a couple different medications that can be given under different circumstances. Are any of the medications given by the hospice team, do any of them speed up the dying process?
No. Um, the reason that question is very common. The two I get the most is, are these medications addictive? And I don't want them to have it. And you're giving them morphine, you're going to speed this up and they're going to die a lot quicker. The answer to that is no. First of all, the amount of morphine that we give, and if you don't want it, we don't have to give it to them. But the fact of the matter is that it does provide them comfort with their breathing. We monitor respirations, we count them, we look for shallow things. We were so good at the different types of respirations that we actually know the amount to give, when to give it, how often to give it, and how far apart. So we're very careful about that. So morphine is one of the most misunderstood medications. So there are things we could do too. But I have to tell you, at end of life, we switch to liquid. We may switch to suppositories because they can't swallow anymore or it's just rolling out of their mouth. But there are things that we can do to make them very comfortable. But no way ever does any hospice speed up death in any way.
Okay. Thank you for taking the time to answer that one. I know that that is a question that, like you said, comes
Yeah,
up a
we get that a
lot
lot.
with hospice care.
Mhm.
Um, and then you mentioned towards the end of a person's life, they tend to not want to drink or eat. Do they still experience hunger if even if they're avoiding food and drink?
No, the body, as I mentioned earlier, the organs in your body have a way of shutting down one by one. There is no hunger. Dehydration is not painful. There are many, many experts on this. So if you're really concerned about that and really have a problem and you're going through this with your loved one right now, I really encourage you to, either call me, I'd be happy to talk with you, or Google it. You could see that one by one, your system, your organs shut down, and it's a very painless process to go through the dying process. So I think the pain really comes from us because we're left with their loss and we know we're never going to see them again. That's where the pain comes from. The pain for them is not there anymore at that point, and they truly, truly are not hungry. Now they may have, as I mentioned earlier too, that the rally. And sometimes when people go through the rally, they'll ask for food that they haven't had in a while, like my dad with the McDonald's. I thought, oh my gosh, there's no way in God's creation he's going to be able to eat, a quarter pounder with cheese. But anyway, I got him one and he did. And he died a couple hours later and his belly was full and he was fine. So you never know what they're going to ask for. So I think that you need to understand that go with the flow. Just go with the flow and talk to your hospice nurse because they know best what to do.
Okay, and the rally, I'm sorry, what was it called? What's
It's
the
called the
term?
death rally.
The death rally. Um, you mentioned that patients will come out of their comatose state during that death rally. How common is it for a patient to enter a comatose state during the dying process?
Pretty common to enter into comatose state before they actually die. I mean, it's not like they're sitting in bed and they're talking to you and then all of a sudden that's it, they're gone. There's a process to this. It's called the dying process. And the dying process goes with all the things I talked about earlier, the circulation, the skin, the nail beds, the coloring, the breathing changes, the pattern of breathing, the urinary uh, becoming less and less urine is being made. All of that is a process that they go through. The rally doesn't happen to everybody. The sad thing about a rally, really, when you think about it, is it gives false hope because it gives families the impression that they've totally come out of this and they're not going to die at all. And you have to really handle that very carefully, because you don't know for sure either what's going on, but you do know that this is very common. And it's written in all the books. It's even in Barbara Carnes's book. The book is called Gone From My Sight, and we give that out to our families. And if you are familiar in hospice and have worked in hospice and you don't have those books for your patients, I highly encourage you to purchase those, because it really helps families prepare for death.
Okay, and the last question we have is, do you think that most families would benefit from either having a death doula on their team and or taking advantage of bereavement services offered through the hospice?
Absolutely. I mean, death doulas, it is a paid position, although some do it voluntarily. So it depends on the death doula. If a death doula is hired by a hospice to be part of the interdisciplinary team, they make anywhere between 70,000 and up. So they are a paid position in some hospices. However, there are people that volunteer to be a death doula, and that's perfectly fine. They are being used more and more. In 2020, 2021, I think you're going to see more of them, because they do so much for the families, and families like to have that connection. The other piece to this is, so does your hospice. So if your hospice fills all of your needs, then of course, that's great. The other thing too is, we're always there for our families. 13 months is a federal mandate by Medicare, to make sure that we follow them for bereavement. And we send cards and letters, and we do support groups, and we make sure that we're with them, at holidays and things like that. And we offer, different things for them to read, and make sure we're there for them. But in addition to that, we offer bereavement services to other types of people other than our own families. For instance, facilities, nursing homes, assisted livings, group homes. We will go in and provide education, bereavement services. Say you have a nurse in a long-term care facility who lost her mother, but her mother was never on hospice with us. We would certainly go in and provide bereavement services for them. And that's because that's what we do. That's what hospices should be doing. So you're going to see more and more of that. You're going to see more and more doulas. It's new. There's probably a lot more to learn about that. So if that's something that you're interested in, I think that's something you should look into and maybe either become one or, support the services that they provide.
Okay, thank you again, Pat, for taking the time to share the presentation and answer questions. That was the last question we have for you today. So thank you again.
Thanks, everyone. I just want to close out by reminding you that our webinars are monthly. The next one will be at the end of November. I can't think off the top of my head. I think it might be advanced directives, might be our next topic. I'm not quite sure, but will be posted way ahead for you to register. Remember to, for any registration or questions about hospice, you can www.azcarehospice.com, and we're always here to answer any of your questions. Thanks, everyone, and have a great day.